Well, good morning to everyone. I'm Dr. Laura Lacher, and welcome to Medical Grand Rounds. We'll go ahead and get started with some reminders, announcements, and logistics before our speaker today. Next week, we will be hosting the annual D.E. Olson Lectureship. That's a very special annual event, so please do join us. We'll be hosting Dr. Anthony Williams from University of Minnesota, who was also a recent guest on the podcast, The Nocturnist, and he will be giving the talk, Storytelling as Advocacy. I'm here today live at Providence St. Vincent in Southern Auditorium. Often you can join us here in person for Grand Rounds on Tuesday mornings, but we are always available on the Teams Live platform. You can learn where we'll be on invite each week for Grand Rounds, and you can earn CME credit by being here watching in the room, by watching live on Teams Live, or by watching a recording of the event, and that recording is always available as the same link as the weekly invite. I'll be monitoring the Q&A throughout today's session, so for those of you online, feel free to post any comments or any questions, and I will mostly hold those as time permits at the end. And now to introduce today's speaker. Super delighted to be joined by Dr. Laura Bennett, the current internal medicine chief resident of the Providence Portland Medical Center Internal Medicine Residency. Dr. Bennett earned her undergraduate degree in biology from University of Washington, and then completed medical school at OHSU before coming to PPMC for her residency. After completion of her chief resident year, she plans to start work as a hospitalist at Providence Portland this coming fall. She had the opportunity to participate in our international rotation in Uganda earlier this year, and we are so excited to hear about her experience and reflections. Thank you so much, Dr. Bennett.
Okay, hi everyone. Again, I'm Laura Bennett. I'm the current chief over at PPMC, and today I'm going to give a talk on teaching POCUS in Uganda, what I learned and what I wish I knew before I went. Okay, so quickly, some disclosures. So I have no financial ties to Health Volunteers Overseas. That's the group that we go over to Uganda with. And then I just want everyone to keep in mind that I am not a cardiologist. I'm just someone who strives to use point of care ultrasound to improve patient care. And then I want to give a special shout out. This is Dr. Ben Pedroja. He is a former chief, current hospitalist at PPMC. He has created a wonderful POCUS curriculum over at PPMC. He's who taught me. It involves a 3-year-long longitudinal curriculum as well as a POCUS elective that you get to have when you're a senior resident. Again, I lovingly call him the POCUS warrior, and so a lot of the materials that we used for teaching while we were over in Uganda were from him. Outline of the talk today. So I'm going to introduce the rotation. I'm going to give some background about Kabale, the referral hospital, and the School of Medicine. I'm going to talk about the role of POCUS, the curriculum that we created, what I wish I knew before I went, what I learned, and then why we should invest in these rotations. So the international rotation. It's a long-standing rotation. I'm sure a lot of you guys know about it. It's 4 weeks long. It's offered to the senior residents at St. V's and PPMC. It was originally started by Dr. Claudia Leonard, which I'm sure you guys are aware of her, and it's still supported by her husband, and a lot of other dedicated physicians. This year we went through, again, Health Volunteers Overseas. It's been in many different countries. It used to be in Kenya. More recently, it was in Mbarara. Now it's in Kabale, Uganda. Our goal is to teach 3rd and 5th year medical students at the Kabale School of Medicine, and then take care of medicine ward patients at the Kabale Regional Referral Hospital. And then ultimately, we reciprocally have students that come from Kabale to Portland and then rotate at St. V's and PPMC. This year, I had the pleasure of going with Dr. Kaylee Bond and Dr. Antonio Cordova. They are 2 senior residents at PPMC. And then not pictured, but other people who also went this year are Dr. Laura Holton, Jamie Beckerman, and then our St. V's residents, Abby and Adriana. So some background on Kabale. So Kabale is, I'm just gonna grab this pointer so you guys can see right here. It's a small town in southwest Uganda. It has a population of around 50,000 people, but the district itself has around 250,000 people. It's about 88 miles southwest of Mbarara, which is the next largest town, and then around 250 miles from Kampala, which is Uganda's capital and largest city. This is the house that I stayed in. We call it the Makanga House. So this house is on top of a very large hill called Makanga Hill. It gives you a great workout every day that you have to walk up it. And then this is the view that you have from our porch, something that we enjoy doing every evening. The house is about 30 minutes away from the hospital. So this is what our walk to work looked like most days. It's very misty in the morning. And then by the time you walk home, you get to see a great view of the city. So the Regional Referral Hospital, it's one of the 13 regional hospitals funded by the Uganda Ministry of Health. It has a bed capacity of about 280 patients, but they tend to have more patients who will just be, on the ground or sleeping in beds outside. It serves a population of about 2 million people from nearby districts, including people from the DRC and Rwanda. And I think you should think of it sort of as a county hospital. So these are patients who are sick enough that they can't be treated at their local hospitals, but they are unable to afford private health care. And it's one of the 15 internship hospitals that are in Uganda. This is sort of a bird's eye view of the hospital, just so you can get sort of the scale of it. So this is where we walk down, and then immediately to the left, this is where the School of Medicine is. This is where their clinics are. And then if you sneak this way, the maternity ward, and then this is where the medicine wards are. So it's a pretty big referral hospital. This is what the outside of a medical ward looks like. This is what the inside of a medical ward looks like. So they split it into both female and male wards. So probably on each side, there's anywhere between like 8 to 16 patients. Often the patients will have their families with them, especially on the female side. So they'll have lots of young children with them. Their family will be outside. A little differently than how we do it here. The patients have to bring their own clothes, their own bedding. Their family brings them food. So it looks a little bit different than maybe what we have here. This is what the School of Medicine looks like. Again, the students get all their didactics here. So it's not just us teaching internal medicine, but they also get their didactics with surgery, OB-GYN, any other amount of teaching that they're receiving. And so you'll often find that in the morning, the student leader from each class will try to get there really early so they can get a room, so we can actually do teaching in a room that day. If not, we had to do teaching outside. We sometimes went to their hostels. We even offered once to do it out at our Makanga house. So even finding space to do the teaching can be difficult at times. So again, we were teaching 3rd and 5th year medical students. We would do lectures in the morning and the afternoon, and then we would round down patients on the wards from about 10 to 1 p.m. And then this was a group of our students that we were with for 3 weeks, the 3rd and 5th years. So who else is there? So there are a few other doctors that help teach the students. There are 2 physicians that are hired on by the School of Medicine. That's Dr. Patrick and Dr. Jacob. So they have an incredible role. So they teach the students, they make the curriculum, they do the evaluations, they do the testing. So they do, 2 people are doing the entire role of what a normal medical school curriculum would do, just the 2 of them. Then they also see patients on the wards, and then they also have their own private clinics that they have to go to in order to supplement their salary. So for instance, Dr. Patrick, he drives to Mbarara, which is about 2.5, 3-hour drive twice a week just to go to his clinic over there. And then he'll drive back to Kabale just so he can do teaching for the students. And then we also have a hospital paid physician. She's in charge of really taking care of all the wards patients, so they're really under her care. And then she's also in charge of teaching the interns. So like I said, Kabale Referral Hospital is one of the internship centers, and so they have interns there. Technically, our role as the volunteers who go over is to teach the medical students, but we do have some overlap with the interns as well. So a big question that we had before we went is, well, what should we teach? And so when we asked the school, they send over a lot of topics, right? And you feel a little overwhelmed, and we knew that we wanted to do, we had plenty of things for didactics. We had things on, heart failure, cirrhosis, all the bread and butter. But what we were interested in was really teaching point of care ultrasound, or POCUS. And so why is that? So, POCUS is something that's been around for a very long time. It's become much more popular. I think it's something that is sort of the standard of care that a lot of residents know that they have to learn in order to move on with their career. But so things that we know that are at this point is that we know it's safe, it doesn't have radiation, and it's good for people who are pregnant. It's fast, it's portable, and can be done at the bedside. It helps avoid unnecessary testing, and it's affordable, which is a really important factor to consider when addressing the inequity that low middle income countries are facing. So I wanted to sort of highlight some of the inequity that's happening in Uganda. So one, they don't have enough equipment. I looked through a national study that they did of an audit in 2020 that looked at all the registered radiology equipment. So that's looking at x-rays, CTs, MAMs, dental equipment, everything. The only thing that wasn't mentioned in this study was MRI, which I thought was really interesting because they don't have to actually be registered. But they found that in the entire country, they only had 625 pieces of equipment, of all radiology equipment. and then majority of those were plain X-ray machines. And so they technically only have 15.5 units of equipment per 1 million people, which is below the WHO recommended 20 million. And then in 2022, there was a national study done that examined how many CTs they had. I was looking at the standardization of CT facilities. They found that there was only a total of 25 CT scanners in all of Uganda. That's 25 CT scanners that's supposed to take care of a population of 48 million people. And 72% of those CT scans were done in private centers. So it's a place that my patients wouldn't even have access to, right? And then if you're wondering, there are no MRI or CT machines in Kabale. The nearest place that you can have them done is in Mbarara, which if you remember is about 88 miles away from where we were in Kabale. So that's a 2.5-hour bus ride, which leads me to my next concern, which is cost, right? So can the patients even afford to get a ride to Mbarara? Can they afford to take the day off work and lose that income? And then if they could, can they even afford the scan? So if you look at the Mbarara Regional Referral Center, their average cost of an MRI is around $300 to $1,200 US. And then the average cost of just a CT of their chest would be $200 to $300. So then if you keep in mind that the typical person working in Uganda makes about $700 a year, there's no way that these people can probably afford any of this, right? They certainly can't afford an MRI, and it's very rare that they can even afford a CT of their chest. And then even if they could, right? So there's a real lack of diagnostic infrastructure there. So even if the scans are there, they don't have the skilled human resources to operate and maintain the equipment. They don't have protocols in place to standardize care and guarantee adequate safety, and they don't have quality assurance mechanisms. So I think this is what we take for granted in America, right? So we just assume that the MRI machine in our hospital is functioning properly, that there's someone there who can actually help the patient get in the machine, that there's someone who knows how to fix the machine if something goes wrong, that the quality of the pictures of the machine are going to be up to snuff. And so that's something that they don't really have in a national level there. And then maybe what's most concerning is there's a real shortage of doctors there. So Uganda, with a population of 48 million people, only had around 2,100 medical doctors registered a few years ago. The current doctor to patient ratio this year is 1.5 to 10,000 people. In the United States, it's 35 doctors to 10,000 people. 48 of them currently registered are radiologists. So you have one radiologist per 1 million people. That doesn't seem like enough. And then 70% of the doctors are practicing in urban areas. Shortages are worse in rural areas where 80% of the population resides. So I got to thinking, why is that? So a big problem is, again, back to salary. So the average salary of a generalist there is around $3,000 to $10,000 per year. And there was a great quote from one of the studies I was reading that says, in search of a better livelihood, healthcare workers are moving within countries from rural to urban areas, within regions from poor to better off countries, and across continents. And so I think a lot of these physicians are just trying to, make a livelihood for themselves, support their family. Like I said before, when I was talking about Dr. Patrick, he goes above and beyond. He probably works harder than anyone I've ever met, and he still is having a hard time making times meet. A way to sort of address that is a concept called task shifting. So the World Health Organization recommends task shifting as a strategy to strengthen and expand healthcare workforce. So the concept is tasks are moved from highly qualified health professionals to health workers with shorter training and less qualifications in order to increase efficiency of available human resources for health. When thinking about it in the lens of POCUS, so task shifting for POCUS is defined as focused bedside ultrasound performed by healthcare providers with ultrasound training limited to the respective POCUS examinations. With the concept that POCUS is a promising task shifting approach, moving sonographic imaging from radiology departments to frontline healthcare. So we know that this has been going on forever, right? So there's lots of studies, usually started in America, looking at emergency room doctors, and we've seen that emergency room physicians have better diagnostic accuracy of differentiating shock when utilizing POCUS versus the standard care group. This is part of the new sepsis guidelines as well. So this is a 2022 systematic review that looked at over 10,000 articles. The primary outcome was diagnostic accuracy of emergency room physicians, and showed that they had improved diagnostic accuracy when evaluating shock compared to the standard group not using POCUS, from 45 to 60% to 80 to 89%. We also know that research supports the ability of non-cardiologist physicians to accurately diagnose pericardial effusions. This is another larger study Evaluating 515 high-risk patients, emergency room physicians were able to correctly identify 103 of the pericardial effusions with a sensitivity and specificity of 96 and 98%. We also know that we're pretty good at assessing left ventricular ejection fraction. There's another study that showed that when you sort of put them in the realms of normal, mild, moderate, or severe, emergency room doctors did a pretty good job of assessing LVEF. So with all that in mind, the goals that we had when we were creating our curriculum, one, we knew we only wanted to teach one organ system. We wanted to do focused cardiac ultrasound given our time restraint. We wanted the students to be able to understand basic concept of cardiac ultrasound. We really wanted them to be comfortable and excited about using ultrasound in the future. And we wanted them to scan patients, as many as they possibly could. A lot of that was possible because we had 2 GE Vscan pocket ultrasounds. So these are, we had more funding at PPMC, so we got new ultrasounds. We were able to take our older ones with us and actually leave them there in Uganda so they could use them when we left. These are, there's fancier butterflies and V-scans, but these use VE pocket ultrasounds on the market now are about $2,000 to $3,000 US. So something that the School of Medicine wouldn't have been able to probably afford if we had not brought them. A big part of our didactics, again, big shout out to Ben who helped us with all this, but we went over the basic physics behind ultrasound, how to interpret picture quality, talking about things like depth, axis, and gain. And then how to hold a probe, talking about if you're trying to get a better picture, fanning, sliding, or rotating. And then we had lots of didactics based on cardiac ultrasound. So major cardiac windows and views, basic assessment of the chamber sizes, like we talked about, LVEF, pericardial effusions, and then IVC assessments. So this is an example of what we'd be looking at. So this is a patient, this is a peritoneal short. Here is the left ventricle, here's the right ventricle. This person has RV dilation that's impairing LV filling so that the septum here is flattening, creating what we call the D sign. This is an evidence of RV overload. So if you saw this for our patient, you'd be worried about anything that can cause RV overload. So things like PE, lung disease, pulmonary arterial hypertension, anything like that. When we talk about evaluating left ventricular ejection fraction, so this is a peritoneal long view. Again, I don't think in the realm of POCUS you could ever say this person's EF is, 14%, right? That's not within the scope of POCUS, but what you could say is, does it look normal? Does it look mild, moderately, or severely reduced? One of the main things we look at is the E-point septal separation. So that's the distance between the anterior leaflet of the mitral valve and the septal wall. Normal is about less than 1 centimeter. So I'll compare A and D. So A is someone who is normal. I mean, I will say they're obviously tachycardic in this photo, but we're looking at, so this is my right ventricle, my left ventricular outflow tract, my left atrium, and then you're looking at the anterior leaflet of the mitral valve and how well it's slapping up against the septum here. And so here you can clearly see that the mitral valve leaflet is hitting the septum, so that's normal. Whereas down here, again, right ventricle, left ventricular outflow tract, left atrium, left ventricle. Between the left atrium and my left ventricle is my mitral valve. And you can see here how the mitral valve is not nearly slapping up against that septum, right? So we would look at that and say that looks like severely reduced EF. Also things we look at, again, the presence or absence of a pericardial effusion. So this is a subcostal 4-chamber view. What we're looking at here again, so left and right ventricle, right atrium, left atrium, and then this sort of black line of fluid here is the pericardial effusion. So this is a small one, medium, and this is a large size. You can also see here this bouncing right ventricle, indicating that this person likely has tamponade as well. And then the last thing we talked about with the students was IVC assessment. So IVC assessment is a bit more controversial, but it's an estimate of someone's CVP, and it can be, or central venous pressure, and it helps guide decisions about IV fluid administration. So here you might be able to recognize that this looks like liver. And then we have our IVC dumping into our right atrium. And then one of our main landmarks that we're looking for is our hepatic vein also to be dumping in. It helps us know that we're not looking at the aorta. We luckily had a really helpful pocket guide that was also helped created by Ben and some other former graduates. So this was, it has all the descriptions of everything that we've talked about. So all the different cardiac views. It also goes through lung ultrasound, some abdominal ultrasound procedures, right? They do lots of procedures there. So how to do an ultrasound guided central line or para or thora. We had a few of these that were physical copies that we had around, and then we had digital copies that were sent to all of the students and the attendings so that everyone in the medical school would have access to them. The students would bring this with them whenever we did our image review, and we did a lot of image review. And so I had probably, you know, hundreds of photos of pathology. We would make every single student look at a picture, tell me what view we were in, how was the quality of the picture, so how's the depth, axis, and gain, and then go over what we had just talked about, right? So how well does the heart look to be squeezing? Do the chamber sizes look normal? Do they see an effusion? And then give me a summary of that picture. And I think, you know, despite all of that, my major goal is I just wanted them to understand what a normal heart should look like so that if they ever were to see something that looked abnormal, they could at least recognize that, right? And so we did lots and lots of image review. And then to help solidify it, we also did case reports. So see if I can get this to play. So this is a case that I took care of a long time ago. So this is a apical 4-chamber. Here you can kind of appreciate that fibrinous, what looks like pretty gross pericardial effusion, right? So this is a purulent pericarditis. And the point of going over this case with the students was to talk about how it affects treatment, going over the concept of a pericardiocentesis, and sort of what the workup looks like for someone who has this. And then we did lots of scanning. We scanned a lot. How it worked is we would split into 2 groups. So I would go off with one of the scanners and the students, and then Dr. Bond and Dr. Cordova would go off with the other scanner and the other students. We would split up on each ward, and our goal was on every scanning day, we would scan every patient, whether they had a normal heart or an abnormal heart. We scanned everyone. We made sure that every student did scanning. They had to do all the 5 different views that we just sort of talked about, and then give their assessment. And I'll say, you know, I obviously like medical education. That's why I became chief. I love giving a talk on hyponatremia as much as the next internist. But there really is nothing as satisfying as watching someone scan for the very first time. The students would, you know, if they ever even got what looked like a heart, the absolute shock on their face every time. First, they were scared. Then they would eventually go through all the steps and accept what they were doing. And then they were so excited. They would be smiling, so proud when they could give a correct assessment. And I think that's what medical education is all about, if I'm being totally honest. I think before I went on this trip, excuse me, I was a little bit burnt out from just having a long chief year. And I think it's moments like that, remembering that feeling, that sort of helps propel you into a long career of medical education, understanding why people have been doing this for so long. And as someone who's really early on in my career, I think it'll help motivate me and kind of help shape sort of what I want to do moving forward with my career. But yeah, it was really, really great. We saw lots of interesting pathology. We'll talk about some of it. So this is just on our first day. So imagine this, my first day, I'm the only attending there, right? So there's no other attendings. And I have no idea how the system works yet, as the first patient I'm ever getting a presentation from. And we don't have power that day, so I can't even like look something up on UpToDate if I really wanted to. But this guy, so he's a 56-year-old former smoker, alcoholic. He had a recent diagnosis of TB about 2 months ago. He can't tell us if he's taking RIPE therapy. He knows that meds were given to him. He's not really sure if he's been taking them. And then again, right, so he speaks a different dialect of a language in Uganda that my students don't even speak, let alone English. So we're going through like a few layers of different language barriers. But he says that he's been having some subacute positional epigastric chest pain. He also notably on his exam has some edema, elevated JVD, and dyspnea. The intern had seen him the day before without an attending and said that maybe it was peritonitis because the patient had abdominal pain, and that's something the intern had seen a lot. They ordered an abdominal ultrasound, a chest x-ray, and some antibiotics. The ultrasound was done. It showed no cirrhosis and some trace ascites. The chest x-ray showed some enlarged cardiac silhouette and pulmonary edema. And then the way that orders work is you write it on a piece of paper, right? And so unfortunately, when they ordered an EKG, what that really means is that there's only one EKG for the entire medical ward. That EKG is owned by the School of Medicine. It's locked in a room within the School of Medicine that the interns don't have access to, right? So the only way an EKG will get done is if a medical student has the wherewithal to read that note, to then go to the School of Medicine, find the key from either me or one of the faculty, open up that locked office, grab it, and then they themselves have to go do that EKG, right? So even though the order was done, the EKG didn't happen until we were on rounds together. But we did it, and this is what the machine looks like. Again, this is what the machine looks like. This is the office that we had. And the patient was in sinus tach, they had low voltage QRS, and then no ST elevations or T wave changes. Not surprisingly, we did some POCUS. And
20 milligrams.
As you can see, again, this is a peristral long. This is my right ventricle, left ventricular outflow tract, my left atrium, my left ventricle. And then
20 milligrams.
You can see here that the mitral valve is not slapping up against the septum at all. So this is someone who had severely reduced LVF. You can also tell it looks like the heart barely beating, right? Like anyone can see that. It doesn't look too good. And then not pictured, it was on a apical forward subcostal. They also had a pericardial effusion.
20 milligrams.
During the presentation, right? These presentations take a while. They do things differently there. Just to present one patient, it usually takes like an hour and a half. But the patient started saying that he felt very unwell. He became sweaty. That kind of like from afar, you can tell like that guy doesn't look so good. We rechecked his vitals and he didn't have a blood pressure anymore. His limbs were now cold. So if you guys remember this chart where we talk about, you know, are they wet, are they cold or warm? He's now living over here in the cold and wet cardiogenic shock realm. So our new working diagnosis is sounded like pericarditis. He really had positional chest pain that was improved when he was leaning forward. It is likely due to TB, which I thought was really interesting. So TB is actually the most common cause of pericarditis in endemic countries, accounting for 40 to 83% of the cases. And again, he had just been diagnosed a couple months ago, and he wasn't really taking his therapy. And we thought that probably put him into heart failure, and then he had tamponade and cardiogenic shock. That patient ended up sadly passing away that evening. But I think what it highlights is that we had a very different assessment of someone's shock, right? So able to differentiate shock. I think had we not done that cardiac assessment and it had just been the intern, they probably would have said this person had septic shock from peritonitis, right? Because that's what they're used to seeing. That's what they're comfortable with diagnosing. I think cardiogenic shock was a brand new topic when we were teaching shock to them. They never even thought to bring it up. So I think it's just a nice example of how we were able to differentiate shock for that patient. But we saw lots of normal hearts. We saw lots of patients who had heart failure. Alcoholic cardiomyopathy is really prevalent in Uganda. There's a real problem with alcohol there. And then one of the cases that I also wanted to show is this one. So this is a patient. She's a 35-year-old female. She just had a baby, I think like 3 months ago, or 3 months prior to her presentation, and she was coming in with subacute exertional dyspnea and fatigue. She'd been at the hospital for a week already. Her initial EKG showed AFib with RVR. They put her on digoxin and fixed dose warfarin. Just for background, they don't have DOACs. They don't have heparin drips. They give warfarin as a fixed dose, and they have no way of checking the level. So they have no idea if they're sub or super therapeutic. They just kind of choose a dose and hope for the best, right? On day like 6 or 7, Dr. Jacob asked me to come evaluate her because she was not feeling so well when I did my POCUS. I don't know if you guys can appreciate, but there's a very large left atrial thrombus right here. It's pretty impressive. That is on an apical 4-chamber view. And so with that in mind, now we're super worried, and there's not a whole lot we could do. We increased her warfarin dose, and then I talked to Dr. Jacob. It was really his patient to take care of, but about just the risk benefits of keeping her on digoxin, right? If she converts out of AFib back to normal, the risk of her having a life-altering stroke are pretty high in someone who's 35 years old, right? So that was just another example of a really interesting case where once we did some POCUS, it sort of changed how we were thinking about management for a patient. Okay, with all that in mind, there were definitely some challenges and limitations that we dealt with. One, you know, for myself, my own limitations. Again, I'm not a cardiologist. I'm still pretty new to doing POCUS. I've only been doing it for a few years. I was in a brand new system, seeing pathology I'd never seen before. We were only there for a brief amount of time. One group of students we had for a few weeks, and then the other group of students we only had for a week, right? So there's only so much you can teach in that time limit. Again, we were often dealing with power outages. So the power goes out like once a day. usually during the work hours. And so either it was we were teaching a lecture using electricity and that would go out, or that even the ultrasounds themselves wouldn't have been getting charged overnight because the power was out, so that's difficult. The ultrasounds that we're using, again, are not the fanciest ones. When you compare the image quality from the pocket V scanners compared to even the new V scanners or what we're doing for formal echocardiograms, it's very different. And then one thing that I found really interesting was trying to get buy-in, right? So it's really important that when we left, the attendings who were still doing teaching had to buy into the concept of POCUS, right? So when we first got there, it was a little challenging. The POCUS is still relatively new. These physicians had not been trained in ultrasound before. And whenever you bring something new to a physician, as we all know, we sometimes struggle to change and to accept change. And so in the beginning, they were very guarded. And I think it was because they didn't know how to use it, right? And I kind of recognized that early on. I made sure that they had all of the learning material that we were sending to students. And then I think the best thing was by the end of the 4 weeks, that last day of rounding with Dr. Patrick and Jacob, they both had the pocket guides in their code, and they were both ultrasounding themselves. And I think that's what we were really hoping for, was to have enough buy-in from the institution that the teaching would keep happening when we were gone. But an unforeseen limitation or complication that came up, something that I wish I knew before I went, rheumatic heart disease, right? So when I think about it now, it seems silly. I should have thought about that before I went. But in reality, like, I've never seen rheumatic heart disease before, and I've only really thought about it for a test question. And when I got there, it wasn't that my patients had a lot of rheumatic heart disease, it's that my medical students did. So while I was there, I think like word got around that I did ultrasound, and I'd be on rounds and students would be coming up to me asking me to ultrasound them because they were ill, because they themselves were sick, which makes sense when you think about their age, right? So they're in their early 20s, right, when rheumatic heart disease starts showing up. We even had one medical student who wasn't mine, but was dying in the intensive care unit of rheumatic heart disease related complications while I was there. And that was something I just was not ready for whatsoever. So demographics, so let's just talk about rheumatic heart disease. So it's the most common preventable, treatable cardiovascular disease in young people worldwide. It globally affects over 55 million people, and about 350,000 people die from it every year. 95% of those cases are happening in low middle income countries. The highest prevalence is in Oceania, South Asia, and Sub-Saharan Africa, where I was. In Uganda, the prevalence is about 3%. It affects over 500,000 Ugandans, and then it causes 17.8% of total mortality. That's from the 2020 World Heart Federation stats. So let's talk about rheumatic fever. So rheumatic fever is an illness that typically occurs 2 to 4 weeks after infection by group A strep or strep pyogenes, usually tonsillar pharyngitis, right? It's usually in younger folks when they're 5 to 15 years old. To diagnose it, I bet you guys do remember the Jones criteria, right? That's something that we had to learn. The most common symptoms are usually carditis. That's in 50 to 70% of patients. People also have migratory polyarthritis, chorea, erythema marginatum, subcutaneous nodules. For diagnosis, you need 2 of the major criteria, or 1 major and 2 minor. Minor criteria being fever, elevated inflammation markers, or EKG changes. And then in 2015, they added a new major criteria, which was echocardiographic evidence of subclinical carditis. These patients also will have elevated ASO titers, anti-DNase positive cultures, or positive strep antigen. The pathology is actually pretty interesting. So rheumatic carditis is due to an exaggerated immune-mediated injury to the heart. So there's a protein and group A strep antigen that looks very similar to the structure of proteins that are already in cardiac valves in the myocardium. And it's a concept called molecular mimicry. And so when antibodies develop in response to the group A strep, they start cross-reacting and attacking the cardiac proteins like myosin, which then leads to inflammation and fibrosis. And then the rheumatic heart disease is a long-term consequence of that immune-mediated injury to the heart and the valves. So again, you get a group A strep infection when you're a kid, it doesn't get treated. 2 to 4 weeks later, you get acute rheumatic fever that can lead to valvulitis or carditis. And then people tend to have high rates of recurrent acute rheumatic fever, have a repetitive inflammatory insult, which then can relate to rheumatic heart disease, usually when people are in their 20s or in their 30s, when they're young. And then the consequences from that tends to be things like regurgitation, stenosis, thickened leaflets, things that we're looking for. There is a diagnostic guideline for rheumatic heart disease. So this is from the 2012 World Heart Federation, and it has a diagnostic echocardiographic criteria. It separates people into whether they're younger or older than 20 years old. And then there's lots of stuff that I don't think we necessarily have to talk about, but again, they're looking at MR, so mitral regurg, mitral stenosis, pathological aortic regurg, and then looking at morphological features, so cord thickening, restricted motion. Some examples of this. So this is examples of mitral regurg. So this is, again, a parasternal long view. This is my right ventricle, my left ventricular outflow tract. That's my left atrium. This is my left ventricle. Between them is my mitral valve. You guys can see this sort of abnormal flapping movement of the mitral valve leaflets as they even go into the left atrium and out. I appreciate that. And then same view, again, right ventricle, left ventricular outflow tract, left atrium, left ventricle, in between. And this is where someone's having that backflow, so significant MR. And then I just wanted to point out that just seeing MR does not diagnose rheumatic heart disease, right? There's lots of reasons why people could have it, but it should just put it higher up on your differential. This is examples of mitral stenosis caused by rheumatic heart disease. So this is an apical four-chamber. This is my left ventricle, my left atrium. And then here you can see a very stenotic, thickened mitral valve leaflet, right? Again, parasternal long view, right ventricle, left ventricular outflow tract, left atrium, left ventricle, very stenotic mitral valve here. So where do I think POCUS can make a difference for these patients? Where it can make a difference is subclinical carditis, right? So that's what I mentioned as one of the new major criteria for the diagnosis of rheumatic fever. What is that? So subclinical carditis refers to patients who don't have clinical signs of carditis. So they don't have a murmur that you can hear when you auscultate, but echocardiography reveals mitral or aortic valvulitis. So prior to doing echoes on these patients, their cardiac dysfunction was unnoticed, and it was assumed that they did not have valve involvement. And it's important because it changes their management, right? So everyone who gets group A strep should be given primary treatment or primary prevention of acute rheumatic fever with penicillin. You can do PO, you can do IM. If they're allergic, you can do Keflex or azithromycin or erythromycin. But as we said, when people have recurrent incidences of rheumatic fever, their likelihood of getting rheumatic heart disease becomes much higher. So that's why we give people secondary prophylaxis as well. That tends to be IM benzathine penicillin. They get every 3 to 4 weeks. The duration changes based on whether or not they have carditis. So this is how the management changes. So the HA guidelines show that if you have no evidence of carditis at all, you only need 5 years of secondary prophylaxis or until they turn 21, whatever is longer. But if they have any evidence of carditis with or without residual heart disease, they need it for 10 years. And you might think, well, that doesn't seem like a lot, but 5 years of treatment is a huge deal in someone who lives in a resource poor country, right? So being able to go to the doctor or go to the pharmacy, being able to afford the medication. Again, they don't have an electronic health record, so how are they supposed to make sure that people aren't lost to follow-up if they move? Those 5 years make a big difference. And the World Heart Federation also agrees. So they changed their screening guidelines in 2023. They created a 2-step confirmation now that show, so essentially non-experts can do screening POCUS in appropriate settings with suspected cases of rheumatic heart disease if people are less than 20. If they find any evidence, so MR, AR, restricted mitral valve leaflet motion, then they should get a confirmatory formal echo. And then something that I thought was interesting, just looking through all the guidelines, they still don't have a recommendation on the frequency or duration of how long people should be getting serial echoes after a diagnosis of acute rheumatic fever. I don't really know why that is. Some studies say it's because they don't have like the funding to make that a national sort of thing that they care about. But yeah, there's still no recommendation on how often or how frequently you should be doing those things. And then interesting enough, they're already doing this. So this is a great study. It's out of Fiji. They train school nurses, right? Because the demographics we're looking for are children, usually between 5 and 15. They went through an 8-week program where they learned about focused cardiac ultrasound for rheumatic heart disease. Because at the time in Fiji, they only had 7 physicians and 1 tech who could actually be doing scans. They de-identified the ultrasounds, and then they were sent to a blinded pediatric cardiologist who reported their quality and gave their own assessment on over 2,000 scans. And then essentially they just found that the quality of their POCUS was overall adequate, so what they called it, 96.6%. They had substantial agreement between the cardiologist and the nurses overall when evaluating things like regurgitation. And yeah, so I think that's really, really interesting. Overall, after brief training, health workers who had no prior experience in echo could obtain adequate quality images and make a reliable assessment on the presence and extent of valvular regurg. So major just teaching points about rheumatic heart disease. So in order to diagnose subclinical carditis, patients need a cardiac ultrasound evaluation. Things to look for are MR, AR, and morphological changes of valvulitis. Detection is important because the presence of subclinical carditis changes the duration of secondary prophylaxis from 5 to 10 years. And then it's reasonable to use POCUS for screening in low middle income countries. However, it does not provide all the comprehensive information. I want to talk quickly about why we should invest in these rotations. So from a residency standpoint, it's a great recruitment tool. This is a study that surveyed over 700 medical students attending 12 different US institutions, and over a third ranked the presence of a global health experience as moderately or very important to what program they were going to be choosing. It impacts our own communities. So this is a study out of Indiana where they evaluated 176 practitioners who were involved in global health engagement and found that they were more likely to be generalists. They're more likely to work with underserved populations, be cost conscious, be involved in global health, or public policy. And then I think maybe most importantly, it can change the course of someone's career. So this is an email that was sent to Amy from someone that she had interacted with during these international rotations, and he actually ended up applying for and matched at a residency in Pittsburgh. One of the highlights from his email just says, I remember coming to PPMC completely unaware of how much the experience would shape and change the whole trajectory of my career, right? And that's why we do this. So ultimately what I learned, one, there's nothing more rewarding than watching someone learn a new skill set. I think it really is the best way to erase your burnout. It solidified my love of teaching. In a place where resources are so limited, having a diagnostic tool that is readily available and can direct medical care can not only save patient lives, but it can also inspire students and doctors, change the course of their career. And then I thought a lot about this. So perfectionism is the enemy of progress. And so I think I've talked to a lot of people since I've been back who say, you know, Laura, I would love to go. That sounds like a great trip, but I haven't taught in a long time, or I don't know anything about tropical medicine, or that just seems like, you know, I wouldn't do a great job. And what I would say to them is the students are not expecting perfection, right? They just want someone who's going to show up, teach them anything. They're so deeply grateful for any amount of teaching. And what they're really looking for is a mentor or someone who just will believe in them and tell them that they can do it. I think that was the biggest feedback we got from the students was, you know, beyond the teaching we gave them, they just loved that there were people there who said, you know, especially the fifth years who are going on to their internship, you guys are going to do great. You're going to be a great physician. Believe in yourself. Keep moving forward. Because they don't have a structure, a medical structure like we do here, where you have support from either senior residents or senior people who are medical students. So I would just say to anyone who's thinking about doing this experience, but is worried that maybe they don't have what it takes, you do. And again, perfectionism should not prevent you from having this really great experience. These are ways you can get involved. So Tim Gobble, he is a former Providence resident. He's actually gave a grand rounds pretty recently. He ended up doing this global health elective, and then he worked in Malawi, and he does a lot of really great POCUS training globally and locally. And so he just created this really wonderful website integrating ultrasound. A lot of the images from today are from his website. So if you want to learn more about POCUS, how to use it in those settings, I recommend chatting or looking at this, and then you can also chat with him. If you want to volunteer, if this is something you're interested in, you should just contact Dr. Claudia Leonard or Dr. Amy Deckett or myself. I'd be happy to help get you involved. And then if you want to donate to the cause, so we get the way that this rotation works is we get donations for both sending residents over there, but then also to have the students come over here and rotate with us. Right now, I think we just got a few more donations so we can have, I think, 2 more students come next year as well, which is really, really exciting. And yeah, any questions?
Dr. Bennett, thank you so much. Super inspiring work. Thank you for sharing your experience. I'll open it up to any questions here in the room or comments. Guess while people are pondering, I'll go ahead and get us started. I'm curious, will you be planning to go back yourself, and how soon, Dr. Bennett?
Yeah, that's great. I absolutely will go back. I've done global health. I've worked in Kenya and other places before, so it's something that I know I really care about. So yeah, I mean, I'd be happy to go back as faculty in the future. I think at this point I've like really been trying to sell it. So I think a lot of faculty now really want to go. So there might just be some more competition for it in the future.
That will be a great problem to have. Sounds good. Amazing that you were able to try to establish some infrastructure in terms of leaving the machines behind and helping teach some of the faculty there. I was curious in general about the opportunity for the hospital to be able to obtain additional handheld ultrasounds in the future. What does that look like for them?
Yeah, I think that would be very challenging. I personally myself didn't talk to the people high up at the hospital because I was really with the School of Medicine, but I don't think that there's a lot of budget for that, or maybe buy-in. Even the buy-in that I found the hardest to get was from the hospital physician herself. So she was a little bit more separate from us. And it's interesting, we talk a lot about like, where does equipment go? Where does the money go? And it's not very clear. One of the things we talked a lot was like there apparently is an EEG that's somewhere in Kabale, but no one knows where. And it's most likely in a private home of someone who's very wealthy. So I think there's lots of cultural differences there, some politics, some things that are sort of beyond my scope. But yeah, I would wish that they could get more ultrasounds there for sure.
I would just echo, thanks so much for sharing the experience with us, and it's super inspiring. My heart was also with those medical students who are themselves experiencing illness, and I was thinking about your quote around perfectionism and the picture of the tamponade solution, which is to put a needle into that, and then thinking about, you know, what it would feel like to the doctor if that doesn't go well, and then what it would feel like to the people, the cultural expectation of healthcare. If the patient expires right after you do a procedure, are you doing more harm than good overall? And I was just curious, kind of your experience with those procedures. When I was there, it was like somebody tapped a thoracic effusion and just left it dripping into a basin on the floor. And of course, the patient got hypotensive, right? And so we helped, but we didn't help the patient. And I felt like when we intervene, it becomes like it was our fault. Whereas if we don't put a needle in and the patient expires, right, it doesn't have that same feel. So I was curious your thoughts.
That's a really, really good point. First, I'll talk about the pericardiocentesis. That was a really funny thing. When we brought it up, one of the students in particular really wants to be a cardiothoracic surgeon. And so his takeaway was that he could start doing that procedure. And so I had to explain to him that that was not going to happen. And we had a very serious chat about that. And I think it's really, really interesting when it comes to doing procedures over there. They don't even usually use ultrasound, right? So they're just going in blind. And so I think the conversation they have with a patient usually beforehand is, are you so uncomfortable enough? Are you okay with dying if this goes wrong? And I think often the patients are very clear about what they want. They'll either say like yes or no. They'll say like, yes, do everything you can, or no, I just want to be left alone, or no, I can't afford that. No, I wouldn't, I would never even want to go to the intensive care unit. And a lot of that is driven, I think, culturally by their religious beliefs. Christianity is most of our patients were Christian. We also have Muslim patients, but religion is sort of the backbone of Uganda. And I think that informs a lot of the medical care that we did there. But you bring up a really great point. I had a whole slide about sort of the ethics of this. And because I thought about it, I thought, would I even have decided to make a formal assessment if the students had rheumatic heart disease or not, even if I knew all this information now? And I don't know if I would have. And I thought about why I felt that way. And you know, in a low middle income country, is the line different, right? Where we talk about frequently, we like to work within our own scope of practice. And that if someone asks us to do something out of that scope, would we ever do that or not? And I think in America, it's easier for us to say like, no, we wouldn't, because we can just call someone else. But when you can't call anyone else, is the line, or does our scope expand beyond what we thought it would? And then the concept of should it, you know, should it be different than it is here? I don't really have an answer. I think we often talk about doing no harm, but is it more harmful to do nothing at all? And I think that is what I've decided is that line is different for everyone based off of their own experience, what's being asked of them, and then the circumstances that they're in. But yeah, I've thought about that a lot too. I don't really have an answer. Yeah.
Thank you, Dr. Bennett. It's actually a very thoughtful answer on a complex topic, area for us all to learn and explore.
I just wanted to make a comment on that same vein, because Abby and I being there, we did have access to an ultrasound at times. And I think what we struggled with was that when you're in a place with such limited resources, it felt like they became a little bit more reliant on the resources they did have. Mm-hmm. And so they're very serious about making diagnoses and assessments and plans based on like physical exam mm-hmm. and the chest x-ray that patients do get, or the history itself. And so we felt like using ultrasound and not being experts in it ourselves and trying to teach it, we were a little worried that we might not teach it well enough, I guess, that people would maybe use it in inappropriate ways. And mm-hmm. so I just wanted to congratulate you on your like good effort to teach them so well, because I can tell just based on like what you showed us, how you taught them and came up with a curriculum, that you really put in so much effort to get each person to scan, and just the basics of the cardiac assessment, I think, was a great thing to kind of go after.
Thank you. Yeah, I totally agree. I think there's lots of anchoring that happens there, right? Just like I mentioned that peritonitis, right? So for that intern, it's no fault of their own, but they saw abdominal pain, they saw TB, they probably thought TB peritonitis, and they just kind of called it a day. And they have access to abdominal ultrasounds. That's the one thing they can get done really easily. And so I think, just to your point of, if there isn't full knowledge of why they're using something or the resource that they now have access to, they could anchor on it incorrectly. And yeah, I think that's probably always going to be a risk for sure. I think it's a risk even for myself, right? Like with that patient, I often thought, was I anchoring on cardiogenic shock? And then I talked it over a bunch with my colleagues, and they were like, no, Laura, like you were right. And I was like, okay, thanks. Yeah.
Great. Well, thank you, Dr. Bennett. I learned a lot. Very inspiring work.